All right, let us begin. This is Sarah Sukumar, and I'm very, very pleased to introduce to you Karen Schwartz, MD, who's the Director of Clinical and Educational Programs at the Johns Hopkins Mood Disorders Center and an Associate Professor in the Department of Psychiatry at our institution. She received her BA from Princeton University and her MD from the Johns Hopkins University School of Medicine. She completed her residency in psychiatry at Johns Hopkins Hospital in 1995, where she served as chief resident. She's leading the Johns Hopkins Department of Psychiatry's efforts to provide psychological support and psychiatric care to frontline healthcare workers. She's also the founder and director of the Adolescent Depression Awareness Program, which is a school-based program designed to educate high school students, faculty, and parents about adolescent depression. In its 21st year, the ADAP curriculum has been taught to over 115,000 high school students across the United States. Dr. Schwartz holds the Myra S. Meyer Professorship in Mood Disorders. I've had the honor of hearing her at the Journey of Women conferences, and she has been such a success there that I felt that our faculty would really benefit from her talk and from the knowledge that she has to share with us. Thank you very much, Karen. Please welcome to our Cancer Center talks.
Well, thank you so much. I appreciate the invitation. This is it was an opportunity for me to put more formally together my thoughts about the history of depression, which, as you can imagine, is a little fraught with misinformation and a lot less data and understanding than we would like. So I'm going to go ahead and share my screen to start my talk. Let's get this to start. So this is quite the title, From Demonic Possession to Chemical Imbalance, an emerging understanding of depression. The problem is we aren't that far away from demonic possession, and we still have people debating about whether depression is actually a medical problem. So that is where we are. I have no financial relationships to disclose. I am not going to endorse any non-FDA approved treatments. I will mention briefly the work being done with psilocybin, which is far from FDA approved. And I am certainly not endorsing that at this moment, although it's intriguing, and colleagues here are doing the cutting edge work related to that. So I'm going to talk a little bit about the way depression has been viewed, starting with Hippocrates, as we always do, talking a little bit about different theories that have been related to the causes of depression, the evolution of treatments, and then I'm going to end by talking about some of the current challenges we have in accepting depression as a medical condition and how those are coming to the forefront during the COVID pandemic. So we'll start with Hippocrates, because that is where documentation pretty much starts. As we know, Hippocrates had the 4 humors. So we had black bile, yellow bile, blood, and phlegm. And depression was viewed as an excess of black bile in the spleen. So the descriptions have a level of distress and despondency that we see in the most severe forms of depression. And this sense of someone being delusionally worried about bad things happening, having done bad things, and then physical symptoms, as we can imagine. Although it was described as a melancholic temperament, it was viewed as a change and something that maybe needed treatment. Of course, the treatments were in no way helpful and involved things like bloodletting, the other things done to restore the humors. The Romans, Galen particularly, talked about melancholia, and I think actually gave some rich descriptions. So the idea that someone who is melancholic, finding fault with life and hating people, but not wanting to die, and this fear of death being a principal concern, this description of dreading death and desire to die at the same time is what so many of my patients now talk about with depression, where you are both tortured. And so you cannot imagine living, although it's not necessarily that you want to die. I also think that in the second description, it really captures what depression is like. The recognition of emotional suffering and disturbed thoughts, the idea that melancholic patients have become a sort of snail, so that they must escape everyone in order to avoid having their shell crushed, while others fear that Atlas, who supports the world, may grow weary and vanish. So this vulnerability, this thought that I am vulnerable and terrible things can happen to me, is so common in talking to patients with severe major depression. Now, St. Augustine and others, as we're moving forward, had the demonic possession idea. The thought is that if you were depressed, it was a punishment from God, and that the most severe forms of depression represented demonic possession. As you can imagine, the punishments were severe. People were beaten, they were banished, they were imprisoned, and all of this was helped them to atone. In some of the old writings from monasteries, you can see that monks that quite possibly had depression were viewed as lazy, temperamental, problematic. And so no view of illness here, but rather it being a lack of moral fiber, quite literally. We still hear that with stigma. Someone saying, well, I'm just not strong enough, I'm not good enough. It's me, and it's that I'm lacking. And that was certainly the way that depression was viewed. Now, in the Renaissance, there was a shift, and it was viewed less as an illness, but more that someone was temperamental. And it was very much associated with artists. Work done by my colleague, Kay Jamison, has demonstrated that link between creativity and mood disorders. So there probably was some truth that there was a preponderance of mood symptoms in those who were very artistically creative. So because this was viewed with creativity, it was viewed as something that people that were in a chosen group had, but not others. So it was thought that you were smart, rich, and talented, that's when you were vulnerable to having melancholia. There's a little bit of that continues today. What I hear from many patients who don't really have an understanding that depression is a medical illness that needs treatment, they will say to me, I don't have time to be depressed. That's a luxury I don't have. Now, obviously, it's not that simple, and that's an inaccurate view, but there's still that feeling that being able to think about your feelings, reflect on your feelings, and perhaps not do things because of how you are emotionally feeling is something that some people feel that they simply don't have as an option. In 1652, Robert Burton wrote The Anatomy of Melancholy. So this is a major publication looking at depression and how depression is viewed. He started by differentiating the melancholic temperament from people that had melancholia. So the melancholic temperament was someone who was dull, sad, sour, lumpish, ill-disposed, solitary, and anyway, moved or displeased. Now, I think there is still this confusion between people who are angry, irritable, and negative, and those who are depressed. Sometimes you cannot tell the difference. And I actually think clinically what we end up doing is trying to get information from families to say, is this how your family member always is? Has your dad always been this way? And what we often hear is, no, he's never this way. This is a change, which is what we see with depression that's a medical problem. Whereas there are people that are simply cranky, irritable, and difficult to be around. So he was making this distinction, but made the point that dispositions become habits, and the habit can become a disease. Now, what I would argue is perhaps he's capturing that some people had dysthymia or a chronic form of low-grade depression, and that group is in danger of what we call double depression, where you go from dysthymia into an episode of major depression. Burton then went on to talk about melancholic disease and captured a number of things that I think you could hear from patients on Meyer 4 on our inpatient mood service. People being afraid that the heaven will fall on their heads, that they'll be damned, the fear of devils, death, that they'll be sick of some such disease, and this idea of trembling at every object and being worried about their own health. That is a very common delusional idea that people with severe depression have, that there's something wrong with their body or that it's rotting. And also being worried about dear friends or allies are certainly dead. I had my first outpatient when I was a PGY2 here. Whenever she got severely depressed, she would call me up and say, my sister's dying. And thankfully her sister was in great health. But these are the kind of this is the phenomenology that has been captured in the 17th century, but is certainly prominent even now. So this sense that people are just suffering and tormented, absolutely captured by Burton. And also, I think in this quote, really capturing what people with severe depression have, that sorrow is an inseparable companion. The remembrance of some disgrace, loss, injury, abuse, etc., troubles them. They are weary of their own lives, and feral thoughts to offer violence to their own persons come into their minds. They are soon tired with all things. And so I think what you're seeing there is the sort of level of distress and torture that is so common among those with severe depression. Now, if you look, again, there are no treatments for any of this. There's sort of a growing understanding that perhaps it is an illness or something that is not simply a lack of character that has to be beaten out of someone. In William Cullen's 19th century text, he again talks about melancholic temperament versus melancholia, the illness of depression. So again, melancholic temperament described as someone who's slow, disposed to gravity, caution, timidity, with little sensibility or irritability, and liable to melancholia and hypochondriasis. When talking about melancholia, he made the distinction between those who had melancholia and those who were hypochondriacal. I will say, and I'm sure all of you who have trained in medicine know, those with severe depression often are somatically preoccupied. And so there is a form of hypochondriasis that doesn't have the other symptoms of depression, but a preoccupation with health, a worry about your own health, a worry about your body's ability to function and to be well is a common part of depression. So Cullen was describing melancholia, the illness of depression, as a partial insanity, captured by an anxious fear and despondency that's coming from mistaken judgment with respect to other circumstances than those of health. So the idea that other things in life were very worrisome and triggering. Now in the Victorian era, we went into the asylum, which is a very dark chapter in psychiatric history. And the very best asylums, people were given kindness, respite, and activity. So in very well-run, often very small private facilities, people were engaged in what we would think of as occupational therapy. They would get involved with activities, they might be involved with gardening or other crafts, but mainly what they got was time and support. Now that was rare. The vast majority of asylums were horrific. They were horrific. People were warehoused, often treated very unkindly and horrifically in many ways. And so this was a warehousing of people and essentially a separating out of people who were ill so that they were not in society. Before, most people were cared for by their families and at home, but this was a time that people were sent away. Very little treatment and very little care, let alone kindness, provided. Now, Kraepelin is a very important figure if you're a mood disorders person. He is a German psychiatrist who, in his 1899 text, which was translated in the US in 1920, he first talked about manic-depressive insanity. And the thing that he was able to do was to distinguish that mood disorders were different than schizophrenia. Dementia praecox or schizophrenia had been viewed as sort of the people that were really ill. And what he did through observation was identify that there was a different group of people, and that group had episodic mood states, depressive states, manic states, irritable states, which we now talk about as mixed states, and then cyclothymia, which is a mild change in mood or cycling of mood. But his descriptions of depression and mania are defining for how we think about bipolar disorder and major depression today. And maybe most importantly, he was viewing mood disorders as a permanent morbid state. So an illness that people had, that while episodic in its presentation of symptoms, meaning periods of illness interspersed with periods where people were well, the thought that once you have this illness, it's something you will potentially be dealing with, and that it's not something that's transient is really critical. I will say that although he used the term manic depressive insanity, he still talked about melancholia. It was actually Adolf Meyer, the first psychiatrist in chief at Johns Hopkins, who talked about depression. Now, Adolf Meyer did a lot of great things, but he was not as rigorous as Kraepelin, in my opinion, and he was a little mushy-gushy, and his great limitation was that he was too open to everything, including eugenics and other horrific things that we should be embarrassed about in the history of psychiatry. So the idea of using the term depression rather than melancholia really came with him, and in some ways, I think, hurt the field by not being quite specific in what we meant by people being in that severe mood state. So you cannot do the history of depression without talking about Freud. Freud and Kraepelin were contemporaries, obviously. Freud, I think most importantly, you have to remember that he was focused on a very particular group of individuals who had symptoms that were not that severe. During the time of psychoanalysis being a predominant treatment modality, psychiatrists would talk about someone being analyzable or not analyzable. And by that, they really meant how ill was someone? Were they so ill that they could not participate in psychoanalysis? And they were often sent to asylums and lumped into this group of psychotic people. Whereas Freud was focusing on people that had milder symptoms, often had personality issues. Some of them certainly had depression, but not the kind of severe depression that led to hospitalization. And so he talked a lot about melancholia being related to loss. And the thought is that your anger about that loss would go inward and lead to depression, or as he described it, melancholia. The thing that's interesting about his focus on loss is sometimes those were real losses, a death or loss of particularly a parent, but often they were symbolic and tied into his idea of these different stages where people would get stuck. I can't say that I find this a particularly useful concept right now, but he was right that early losses are important in depression. More recent work looking at genetics, particularly the genetics of the serotonin transporter gene, have shown that having multiple serious events, adverse childhood events, is associated with a higher rate of depression later in life. And so that is something worth tipping your hat to Freud, that he wasn't wrong about that. How he was approaching the rest of it was a little off base. Now, I want to talk in the history of psychiatry a little bit about medicine, because this idea that these were true medical illnesses that could have treatment that wasn't simply kindness and time or psychoanalysis came from antihistamines. So methylene blue, a dye, it had a derivative that was an antihistamine. And as is always the case, once one antihistamine is found, you look for other things that have similar chemical structures. And so in 1952, chlorpromazine or thorazine was identified as something that was very like promazine, an antihistamine that was found related to methylene blue. Now, chlorpromazine was the first medicine for psychiatric problems. And now we don't use thorazine because of its significant side effects, particularly those related to being an antihistamine where people are exhausted, often dizzy, would have significant orthostasis. But it revolutionized things. And then the first antidepressant, which you can see is somewhat related in chemical structure found, was imipramine. Imipramine was first used in Europe in 1957, and then in 1959 was approved for use in the United States. Now, a few years ago, I was teaching a history of psychiatry seminar with our fourth-year residents, and one of our residents had met a former Phipps resident, a psychiatry resident from the 50s at Johns Hopkins in a neurology clinic. She was doing a neurology rotation, and she was supposed to talk about this era from the chapter she was to present. And she said, may I just bring this gentleman instead? Because they had a long chat about his experience, and they had stayed in touch. And I said, well, that sounds perfect. The most interesting seminar I've ever been in had this physician describing beginning his training in the Phipps building when there were no medication options, and one hoped that time and essentially occupational therapy and some supportive psychotherapy would be helpful. He described going to visit an asylum because most psychiatrists would become directors at asylums and being completely demoralized and wondering if he should go back to medicine. During his residency, first Thorazine and then imipramine were introduced. And he said with that, his level of hope and the level of hope with his colleagues just skyrocketed, because there was a sense that there were things that we could offer our patients that would lead to a change in their suffering in a short time frame. And so with the advent of these medications, we had a major shift from anger turned inward toward neurotransmitters. Now, I don't think anyone doubts now that major depression is a medical problem that's a brain disease, but in the early 60s, it was revolutionary when they were talking about the catecholamine hypothesis of depression and the idea that monoamines, norepinephrine, dopamine, and serotonin were central to depression. And so this revolutionized everything. And I think a number of my colleagues, especially those who focus on psychotherapy, have been appropriately distressed that we've turned so much there that we think that that is going to be the way that we will find all the answers, which I can tell you is certainly not going to be the case. And in some ways, I think we might overvalue or oversimplify at least the role that these neurotransmitters have, because we do not understand them yet. You know, we've advanced since the 60s, but not a dramatic way. This is not a talk where at the end I'm going to be able to say, and now we have it all figured out, because we don't. But what we have is this belief that we have an understanding of neurotransmitters that is greater than it is. When you talk to someone in the community, what they'll often say to me when I'm talking to them about depression, I'll say, well, what's your understanding of the cause? And they'll say, oh, it's a serotonin deficit. What I can assure you is that if it were a serotonin deficit, it would not take 4 to 6 to 8 weeks for antidepressants to be effective once at a therapeutic dosage. It's dramatically more complex than that. What we know is that certainly that's a part of the story. So what happens when you give an SSRI, for example, is that there will be blockade of serotonin reuptake. So they are selective serotonin reuptake inhibitors. The old tricyclic medications like imipramine, nortriptyline, were both norepinephrine and serotonin reuptake inhibitors with a preponderance of norepinephrine activity, but with both. So SSRIs will block serotonin reuptake. There'll be a buildup of serotonin, again, balancing the deficit perhaps. We know from work at the NIH that what then happens is that there's binding to receptors on the postsynaptic neuron. There's then downregulation of some of these receptors, and it's downregulation that's been associated with clinical response. The problem is we then have this whole cascade that we're doing the hand waving of saying, oh, it's second messenger effects. And we all know that that's hand waving. So we have second messenger effects. All right, what does that mean? That means we don't know. I highly suspect that we will later learn that there's a cascade of maybe 20 or 30 steps. It likely involves proteins being made, messenger RNA being turned on, but you know, that is what some colleagues are focusing on, thank goodness, because we have a very cursory understanding of the actual function and changes that happen in the brain. What I'm sure of is that inadequate doses that don't penetrate the blood-brain barrier are essentially clinically useless. And there is a complex series of things going on. You know, this is not someone with the stomach flu with low potassium that can be corrected in a couple hours in the ER. This is dramatically more complex. We also are understanding that there's going to probably be an important role for cortisol, different kinds of inflammatory cytokines, and this interaction between the inflammatory immune system and depression as well. Again, this is early days in understanding, but it being simply a change in neurotransmitters is almost certainly not going to be the case. And again, as I said, we do know from very carefully done cohort studies that multiple adverse effects in childhood is highly associated with developing major depression at higher rates later in life. So it's a complex story. The brain's a very complex organ. Now, I want to mention something about psychotherapy, and that is because we don't believe that it is simply a one way, oh, you have a chemical imbalance or there's something up with your neurochemistry, therefore you have depression. We also think that going through stress probably affects that. And there is no way that negative effects aren't having changes to the brain chemistry. We know from studies in OCD, for example, PET studies, that doing effective cognitive behavioral therapy can change the neurochemistry. So there's every reason to believe that stress or negative effects can be changing the neurochemistry as well. Aaron Beck at the University of Pennsylvania was the founder of cognitive behavioral therapy. And his thought was that these negative feelings, maladaptive thoughts and beliefs were driving the development of depression. So the thought was that if you challenge negative thoughts, that you will be able to change behaviors and change feelings. With CBT, there's the idea of this triad. The thoughts can drive behaviors and feelings, and the focus is challenging thoughts, recognizing that you can't just say, well, I'll feel differently. But if I challenge my thoughts and I change my behaviors, that can drive positive change in emotion. And cognitive behavioral therapy is tremendously effective for mild depression and a great supplemental treatment for moderate to severe depression. So where are we now? In 1980, the DSM-3 was released, and that was a major change. If you look at the DSM-1 or DSM-2, they're sort of bizarre descriptions of something that might be an illness. There's nothing about it that's reliable. There's nothing about it where you're trying to look for a syndrome. That idea of a clinical syndrome where you see a group of symptoms coming together and staying was not the conception. So coming out of work done mainly at Washington University in St. Louis, the thought was we need to move toward a more reliable diagnostic structure. What I can tell you at the DSM, it's controversial in that it's far from perfect, and there's a lot of politics coming out of the meeting rooms of what should or shouldn't be included. But I want to share that one of the diagnoses that has changed the least from DSM-3 up through DSM-5 is depression. And why is that? Well, because there really is a clinical syndrome. There's no doubt that there are a group of symptoms that come together and stay that roughly fall into these three broad categories of mood change, neurovegetative or physical symptoms, and then self-attitude change. And that combination has been sustained. You know, I was cleaning up my home office, as so many of us have in this pandemic, and I found my note cards from 1988 in my psychiatry rotation, which I'm sure I kept for sentimental reasons. I only kept two. One was about Prozac and one was about mood disorders, given that that's what I've made the focus of my career. There's not a lot different that I can add from the note card I made as a review in 1988. Why? Because we know what depression looks like. We know how to do a clinical assessment and are quite reliable, not perfect, but really quite reliable in making that diagnosis with enough time and a patient who's well enough to be able to engage and describe their internal experiences. So the mood changes can be sad, can be irritable, can be feeling nothing. And there's also anhedonia, this lack of capacity for joy. Interestingly, fewer than 50% of those with depression actually describe feeling sad, which is a major issue because when we use the word depression, as opposed to say melancholia, people say, well, I'm not depressed, as they're irritably telling you they're not, or I just don't feel anything. Like, why are you telling me I'm sad? So sad or depressed is not always the best word to capture this. The physical changes are everything that's on every screening questionnaire, right? Appetite going up and down, sleep being interrupted. Sleep is critical and almost always effective in depression. A sense of fatigue, a change in thinking, cognitive distortions that were so beautifully described in some of the earliest descriptions, where you just can't think and everything gets twisted to the most negative version. And then finally, the last 2 points in this slide capture what we call self-attitude change. The mild self-attitude change that I see among outpatients is when people lose their confidence and they believe that perhaps they're not a good friend, they're not a good mother, they're not a good doctor, they're not a good scientist. You essentially lose confidence in what you care about most. But in severe forms of depression, it becomes feeling truly worthless, feeling guilty, feeling that you contribute nothing. And you can see how that can be highly associated with believing that others would be better off without you and having suicidal thoughts. So this is the clinical syndrome as described. And with the DSM, you're looking for at least one mood symptom and then 4 other symptoms that have come together and stayed for at least 2 weeks. We never see anyone clinically in 2 weeks. And interestingly, from a national survey, we found that the average time of delay from the onset of symptoms to actually getting treatment is 8 years for major depression. And I make that point just to reinforce that it's an episodic illness that is often not recognized despite our knowing what it looks like. So now I'd like to talk a little bit about evolving treatments of depression that have gone along with the history. Needless to say, I'm not going to talk about things that were commonly done that were in no way treatment, punishing people, abusing them, bloodletting, or even insulin shock and things that were not effective for depression. Really, the first effective treatment for depression was electroconvulsive therapy, and I'm going to make a few comments about that. I'll talk briefly about medications, but what I want to make a point of now is that psychotherapy is critical. Almost every study that has looked at the imagined 2x2 table of psychotherapy alone, medicine alone, neither, and the combination has found that the combination of medication and psychotherapy is superior for the treatment of depression. For very mild depression, all kinds of treatments work. Medicine alone works, psychotherapy alone works, exercise works, many things work. But that level of depression rarely comes to medical attention. That's where someone understands, if I'm better about my sleep and keep myself busy, I feel better. I'm talking about more severe depressive symptoms that really require a more formal intervention and often very formal treatment. I'm going to mention some of the novel treatments that we don't know a lot about, but that have people excited because they're different. Most of our medications are very much me too, and focused on targeting the neurotransmitters, norepinephrine, serotonin, and dopamine. So for ECT, what most people in this country know about ECT, even in 2020, is the movie One Flew Over the Cuckoo's Nest. I am sorry that that was an outstanding movie that won a bunch of Oscars, because it means it's shown repeatedly, and people are still having this horrific image of ECT from the 40s and 50s in their mind when they think about it. On this slide, I have the Johns Hopkins website, where this is an image from the website where my colleague Irving Reddy, who's our brain stimulation expert, if you Google Johns Hopkins Psychiatry ECT, it will take you to his Discoveries of Tomorrow talk about ECT, which really debunks so many of the misconceptions that are still out there. I want to share a little bit of context. So I was a PGY2 starting in 1992. And when I called my parents and said, oh, it's interesting, I'm going to be doing ECT this week, my father had a very strong reaction. He had been in the National Guard to pay for school and ended up working as a medical technician during the Korean War. And he was running a blood bank stationed out in Kansas. And as one of the sergeants in the medical corps, he would participate in ECT because they would get 4 big guys to essentially hold someone down while they got ECT without anesthesia and without muscle relaxants. So my father's reaction to mentioning that I was going to be learning about ECT was to say, I cannot believe Johns Hopkins is doing that horrific treatment. And I said, well, it's not a horrific treatment. And what are you talking about? He described that. I said, well, of course we're not doing that. That would be terrible. And then I described what it is when someone gets anesthesia, they're asleep, they have a muscle relaxant, and if everything has been dosed correctly, you will see wiggling toes and nothing else. And so ECT is life-saving, but there's tremendous misunderstanding about it. Prozac revolutionized treatment. So before Prozac, which was approved by the FDA in 1997, pre-Prozac, I'm sorry, that's 1987. I don't know why I made a typo there. Pre-Prozac, we had ECT, tricyclics, and monoamine oxidase inhibitors, and people were terrified if they were not a psychiatrist to prescribe tricyclics that are very dangerous in overdose and monoamine oxidase inhibitors very dangerous in overdose. With the advent of Prozac and the SSRIs, we completely changed who was treating depression. At this point, 80% of antidepressants are prescribed by non-psychiatrists. The majority of depression treatment is happening in primary care settings or by others. The issue is whether we are doing a good job of that. So the National Comorbidity Study, one of the defining epidemiologic studies of mood and anxiety disorders done in this country, had included over asking about once they determined that someone had depression or not, they also ask about any treatment depressive disorder, and this is comparing it to bipolar disorder, generalized anxiety, and panic. Those who had minimally adequate treatment were 15% or fewer in general practice. Other studies have shown that fewer than 10% of those with major depression ever get an adequate course of treatment, either intensive psychotherapy or a medication at a therapeutic dose. Now, when you look, the psychiatrists have trouble believing that it can take 4 to 6 to 8 weeks for medicine to work. So intensive psychotherapy and education needs to be a part of that. So what it really comes down to is a lot of inadequate care. We have new treatments like transcranial magnetic stimulation, which is now FDA approved. If I had been giving this talk 10 years ago, I would say, well, they're talking about this, but it really doesn't work. I think now that we have more powerful magnets, more specific targeting of the limbic system with the magnets, that we're starting to see patients really benefit. In no way more effective than medicine, but for some, we're taking medication as a problem. We're launching an S-ketamine clinic here. My ketamine data from the treatment studies, there's an enormous placebo response. And so it does distinguish itself. There was a split among the FDA committee data was not.
Karen, we are losing you.
It looks like Dr. Schwartz disconnected. Hold on for just one moment. Dr. Schwartz, you are muted.
I apologize for my technology. I think I'm unmuted now.
Okay, fantastic. Are you having problems with your Wi-Fi or your internet connection?
I seem to be, although it seems to have fixed itself. So
okay, I recommend turning off your video feed then.
And restart. I apologize. All right, so what I will...
also, if you could share your screen.
Oh, I thought I had. I apologize. Okay. About to say I'm a bit compelling data. And for Scylla, you
Dr. Schwartz, it looks like the audio has cut off again. What I could do is I could share the presentation on my end, and you can control my slideshow. Dr. Schwartz, if you'd like, I can share my screen, which would have your presentation on there. And you can control you can control the presentation from my end, so it saves you some bandwidth. Let me know if you'd like to do that.
That sounds great.
Okay, great. Hold on for just one moment then. So I think you were last on slide 23, if I'm not mistaken.
I think that is correct.
Let's see here. Go ahead and do this from my end. Share screen number 2. And I'm about to pass over remote control access to you, so you should be able to advance a slide on your end. Let me see if I can find you. There we go.
Okay, thank you. So I was railing against psilocybin, which is what it is, and saying that we do not have we don't have anything yet that talks about efficacy. We do have some information about genes that might be helpful for metabolism, but not efficacy. So where we are is that we have a clear clinical syndrome. Major depression is without a doubt a medical disease. We can identify it. We know that it involves the brain. There's growing evidence that neurochemistry is important, but probably other things, including cytokines and other things like cortisol, other hormones. And we are behind in really understanding brain structures. There's hints of things, the hippocampus being important, the limbic system, but that is behind where we would like it to be. But what we also know is that depression is a complex illness where we combine treatment of a disease with psychotherapy, with medication, with who the person is, the other things they do. As you can imagine, having a problem with alcohol or eating disorder or something of that sort on top of a mood disorder complicates treatment. And this is all happening to an individual person. What I wanted to do last is just make a couple brief comments about where we are with COVID. This is a model of how we respond to disasters developed by George Everly, who's on our faculty and a disaster psychiatry expert. Many of us have seen this, the idea that our emotional well-being from high to low drops when the pandemic or other kind of disaster hits, initially responds as people respond and then crashes down into a disillusionment phase. What I will say is that we're now having the challenge of another wave on top of disillusionment, which is really problematic. The disasters of uncertainty that combine a lethal threat with a long duration and ambiguity, all of which COVID-19 has, leads to the greatest number of psychological consequences, negative consequences. Michelle Obama was talking about having some form of low-grade depression, and I think a term that a lot of us have been using is COVID depression. And are you having COVID depression, meaning something more akin to grief, where you're demoralized and frustrated, or are you having something that is more serious? A recent study, the Climb study, compared data from 2017-18 to 2020 using the same PHQ-9, a standard depression measure. And what you can see is that there was a dramatic increase in those who were meeting criteria on this screen. So it went from roughly 7%, 7.5% that would be positive on the screen to 28%. And what's even more concerning, in the group that are moderately severe to severe, which is a PHQ-9 of 15 or greater, where we have a sensitivity and specificity of 95%, that those rates are going from 3% several years ago to 13%. And so we know we have these much higher rates of anxiety and depression. The CDC has been doing pulse surveys where we're seeing a tripling or quadrupling of the rates of those who screen positive for depression or anxiety. Again, not all of these individuals have major depression, but they have a level of distress that warrants some kind of assessment at least. Lastly, I just want to show some data from a survey that was recently published in the Morbidity and Mortality report that got a lot of press, where they used 2 screening measures to look for symptoms of depression and anxiety, but also asked about substance abuse and suicidal ideation. What we found is that particularly in the young adults, they had incredibly high rates. And I think a lot of this comes from their own frustration about not being able to be at school, be at work, moving forward with their lives because of the limitations of the pandemic, with much lower rates among older individuals. And I do hope that life gives you some kind of resilience. And then dramatically higher substance use, where you've added to, started, or increased your substance use among that younger group. But most concerningly, a quarter of them are saying that they have seriously considered suicide in the last 30 days. So this is not simply COVID depression. I think we are seeing a genuine explosion in the rates of those who have something more serious. And so I just want to end by saying something about stigma. For our medical community and for the community in general, this idea that depression is a treatable medical illness with symptoms we can recognize with good reliability and treatments that are not perfect, but good, especially if used carefully, has not changed whether people think that they question whether depression is a real thing. I have spent 20 years leading a program where we go into high schools to teach kids about depression. So I've done hundreds and hundreds of community presentations. And I can tell you that the average adult that I encounter questions whether depression is a medical problem. And I worry that we in medicine worry and question that too. Right now, we are all under tremendous stress. And I just want to put up the resource of the Office of Wellbeing, which is something where if you are looking for mental, emotional, or spiritual support, it can tell you how to connect to a number of different resources being offered through a multi-department, multi-resource collaboration. So I'll just conclude before we go to questions. What do we know? We know how to diagnose, and we know the syndrome. We have very good treatments, but they are not perfect, and it's exciting, but not yet at the point of improved treatment, some of our new novel treatments. But we have a tremendous problem because we do not recognize depression as a medical illness. And the lack of recognizing that continues to lead to very high suicide rates. And in our current situation, I worry that we're going to be at risk for increasing numbers of those who die from suicide by not having depression treated. In general, medical people are terrible patients. We're just terrible patients. And so I'm just urging all of us to take care of each other. And if you have colleagues that you're worried about, to reach out. So I apologize for technology. I've learned to just know what I can and can't control. So that's what that is. But I'd be very happy to take questions at this point.
Thank you, Karen. Thank you very much. Any questions from our audience?
Psychotropic material. Sure. So psilocybin is obviously it's derived from magic mushrooms. It's this cousin of LSD. The thought is that if you give very low doses or micro doses of psilocybin, that will allow for an exploration and a resolution of underlying problems through an intensive 8-hour, what they're doing at the BPRU is this intensive 8-hour session that involves particular music, having an intensive exploration. The issue is that's exciting. There was recently a JAMA Psychiatry article that showed that it was very helpful. What they're doing right now is being tremendously careful in who they're selecting. So is there a group of people that do not have severe depression that this could be helpful for? It seems that there is. What I'm not sure about, because I really believe in the power of intensive psychotherapy, I'm not sure, and I think we still have to learn more to see, is it that psilocybin allows you to have a different psychotherapy experience? That's quite possible. Or is it that the luxury of an intensive 8-hour psychotherapy session with tremendously experienced psychotherapists is also very effective? So that's just my own, sort of thought about it. But I think we have a tremendous team out on the Bayview campus studying this as carefully as anyone in the country. So we're going to learn more.
So I have a question, Karen, and that is regarding people who don't necessarily show sadness or a depressive tendency, but really do suffer from it. How do you identify them in your family or in yourself?
No, absolutely. No, you've hit it, Sarah. You've hit one of the biggest problems. Most people will fake it around others. I can't tell you how many people they've said, oh, no one at work knows. And I've talked to their work later. It's like, we had no idea, because you can put on a happy face. You can force yourself. So we ask different things. For example, when I'm talking to the high school kids, I'll say, look, you might protect your grades. And I tell the teachers, they might protect their grades because their freedom or being allowed to do things is often linked to grades. But ask, how long does it take? So what do I ask faculty members if I'm talking to them? I say, is it taking you longer? Is it hard to do the work that involves thinking rather than just doing? So science and designing experiments and writing the papers, much harder than going to clinic and seeing the patients. Not that the clinical work's not important or challenging, but we know how to do that. We've been trained to do it in a way that you just do it. So you can be at the bench and pipette, something repetitive. But when you have to think, or to quote a faculty member I took care of years ago, she said, I can write the talk and give the talk. I worry about the questions, especially at a big national meeting where I'm going to get challenged, because that takes a different level of brain power and energy. So what I try to do is to say, is it taking longer? Are you miserable? Are you lacking the ability to enjoy anything? Those kinds of things. But that's where I think education and sort of getting it out there for people is helpful, because they will recognize in themselves, even if they're not allowing others to know. And sometimes, unfortunately, if it keeps getting worse, you do start seeing, oh, you're not quite meeting the deadlines. You're much more irritable in the meetings. What is going on with you? And so I think we're so trained to just say, I'm fine, let me keep going, that there's a problem. Great question about acupuncture or non-Western approaches. I have a number of my own outpatients who have had tremendously good experiences with acupuncture. Now, I'm seeing people that have severe enough symptoms that they almost all need medication in addition to psychotherapy. So they're doing it as an adjunct. I I would suspect that it would probably be like exercise and less formal psychotherapy that for mild symptoms, it would be quite helpful. But I've seen a number of people have it be a really positive adjunct treatment. And I think the key with acupuncture or any of those non-Western approaches is to make sure that you have a skilled practitioner. Not everyone is great at, sort of this idea of like, oh, okay, but you really want a skilled practitioner. You don't want to fall into the trap of having someone that doesn't quite know what they're doing, because that's dangerous too. I mean, it could be dangerous in that they're going to harm you, but also it's not likely to work.
And Karen, since we are in an academic setting and we are constantly rejected as far as grants are concerned, and this is a growing concern all around the institution, there is a very special kind of depression that sets in because of that particular rejection. Do you have any tips, any ways of how we can help others as well as ourselves?
Absolutely. So the one thing that I think we all need is very particular support from our colleagues, right? I mean, I remember my mentor, Ray DiPaolo, our former chairman. He was my mentor from the time I was a second-year resident, telling me the story of his first grant and how many times it got rejected and how many times, and doing that to set up the expectation that this would be a process, and sitting down with me and looking at the pink sheets and saying, now look, this is actually good news, or let's try to do this other thing. And I don't think there can be enough said about great mentors normalizing the rejection process for papers, for grants, for, just getting blasted at a national meeting. I have always talked to, one of my roles is being the vice chair for faculty, and I really try to talk to anyone before they give their first grand rounds and describe that grand rounds is kind of like being at family dinner. People are going to be much more likely to be gentle in their criticism, not at your own institution, versus here you are with your siblings and your uncles and aunts, and they're just going to say, wait a minute, that makes no sense. I mean, people really have a moment of that. And so I think the thing we can do for our junior colleagues and our colleagues, because it's not like the rejection stop, is to be supportive and to normalize it. Say, look, it's great that we're in academics. We have an opportunity to help in a way we can't otherwise. But guess what? This is something we all have happen. And so I think that's exactly right. Now, for some people, the stress of it could trigger something more serious. And then you want to think about that. Not everyone that gets 1 million rejections will have depression. Some people that aren't getting rejections could. There's really an underlying biologic vulnerability that gets revealed and is sometimes revealed by these kinds of, very stressful circumstances.
And I have to state that the rejection doesn't feel any less sort of bad, even if you're as old as I am. The rejection hurts.
Rejection hurts, even when you can say, I'm so accomplished and I've done so much. That's not what we think. The other thing is that if you take 1,000 academics, more of them are going to be on the introverted side, where they're trying to avoid being in trouble. Extroverts can say, oh, well, I'll resubmit it and move on and not worry about it. More of us, certainly I, am on that introverted side where you sort of sit there and think about your failures rather than celebrate your victories and move quickly past your failures. So that's part of it too.
Very true. And on that note, if there are no more questions, I thank you very, very much for this talk. All of us need it at any time. And so thank you. We were honored.
Well, thank you very much. And again, sorry for technology, but it's 2020 in the middle of a pandemic. So thank you very much.
Thanks. Bye-bye.